Good morning, Peter Goertz. I'm a psychiatrist. As doctors, are we doing more harm than good prescribing benzodiazepines for patients? That's always something to consider on an individual case basis. So, benzodiazepine withdrawal. I was called to see a patient and the consult request said psychiatric illness, needs medication. So my understanding was the patient needed medication to stabilize her psychiatric illness, but it turned out to probably have been something quite different. The patient was noted to be hallucinating, delusional, confused. When I talked with her, she did not know the month or year, and it had been puzzling because she was in the hospital for a medical reason, an older lady. And it turns out, when I looked at her chart and checked the state website for controlled substances, it turned out she'd been taking a significant dose of a benzodiazepine, or at least prescribed a significant dose of a benzodiazepine, and she'd not been getting the benzodiazepine regularly in the hospital. So my feeling was the so-called psychiatric symptoms could have been due to benzodiazepine withdrawal. Another patient I was called to see this many years ago, he was on a surgical service and he was scheduled for an operation, or had just had an operation, and he'd been in the hospital a few days, and I was called at night, and the patient was hearing voices and they were not sure what that was due to. He had no known psychiatric illness, but it turns out that patient had been a heavy drinker, a young gentleman, but already quite a heavy drinker, and was probably hallucinating from alcohol withdrawal. So signs of benzodiazepine withdrawal, which can be similar to signs of alcohol withdrawal, they both affect gamma aminobutyric acid, so GABA. Signs of benzodiazepine withdrawal can be elevated heart rate, high blood pressure, sweating, tremor, hallucinations, delusions, seizures, and confusion or delirium. And delirium means that the confusion waxes and wanes. And one can really be blindsided, like I mentioned in those two examples. The first patient on the benzodiazepine had obviously not given a history of taking benzodiazepines recently, or had not been asked. And the second patient, had maybe not been asked about alcohol, at least not in detail, or he may not have said that he'd been drinking a lot of alcohol, even when asked. So we want to try and get a history, but it's not necessarily reliable. The patient may not say the truth. We can check the state website for controlled substances, but even then it can be tricky, because if you see on the state website for controlled substances, the patient's been prescribed 90 tablets for 30 days of Xanax 1 milligram, you might assume they're taking that medicine, but they may not be taking it at all. They may be selling it. So it can be really confusing, and you want to, if possible, get a urine toxicology screen to see if they have a benzodiazepine in their urine. So all this can be like detective work, but it can be quite enjoyable and creative, and you can enjoy doing it. It can be fun to do, but can be very tricky. And there are multiple things to think about. Another thing that can help for sure is getting collateral information, like from the family. But again, they may know what the patient's being prescribed, but they may not know whether or not the patient's taking it, for example. So as far as treatment, if you feel a patient is in benzodiazepine withdrawal, and like, let's say the first patient, already delirious, and in general, if you feel they're in benzodiazepine withdrawal, you want to restart a benzodiazepine. It doesn't necessarily have to be the same benzodiazepine that they were taking prior to hospitalization or previously. So let's say a patient was taking Xanax prior to being in the hospital, and they start withdrawing. you may be able to start Klonopin instead of the Xanax, and you just want to be careful with the equivalent dose. Klonopin is ballpark twice as potent as Xanax, so if someone's taking 3 milligrams of Xanax a day, they would need about 1.5 milligrams of Klonopin a day. One advantage with the Klonopin is the half-life is about 30 hours as opposed to Xanax's half-life being about 10 hours. So the Klonopin gives a more steady level ultimately in the blood, so that may be easier as far as treating the benzodiazepine withdrawal and not getting signs of withdrawal between doses. So when you restart the benzodiazepine, you want to monitor and see if the patient's confusion improves, if the vital signs improve, because people can be confused for totally different reasons. So it may not be the benzodiazepine withdrawal, even if they were taking benzodiazepines prior to hospitalization. And ultimately, if the patient wants to get off the benzodiazepine, or if you want the patient to get off the benzodiazepine, you want to gradually, sometimes very gradually, taper the dose down and ultimately discontinue it. So bottom line, or one aspect for prescribers, is before prescribing a benzodiazepine, you definitely want to be very careful and consider the different aspects, including the negative aspects potentially, of prescribing that benzodiazepine. Thank you.